If you've ever watched those old black and white movies, you probably recognize that scene, right?
Yeah.
The worried family, the serious doctor, and then the line, "I'm afraid she's had a nervous breakdown." It was such a vague, almost dramatic term.
Oh, absolutely. And it often meant, being whisked away somewhere, reflecting how little we truly understood back then, scientifically speaking.
Exactly. But thankfully, things have really changed. We've moved light years beyond that.
Definitely. Modern psychiatric care is grounded in science, in research, and in, well, much clearer frameworks that focus on the person. That old ambiguity, it's gone, replaced by actual definable criteria.
And that shift is precisely what we're diving into today. We're going deep into the absolute foundations, the core ideas from Chapter 1 of Varcarolis Foundations.
Yeah.
So if you need that shortcut, that solid understanding of the essential definitions, the frameworks everyone's working with now, and where the psychiatric nurse fits in, well, you're in the right place.
Okay, so to build that foundation, we really have to start with the basics. Health versus mental health. The World Health Organization, the WHO, gives us a great starting point. They define overall health not just as, not being sick,
Right.
but as a state of complete physical, mental, and social well-being. It's holistic.
And that mental part isn't optional, is it? It's fundamental to that complete picture. The WHO sees mental health as the state where you can realize your potential, handle normal stress, work productively, basically contribute to your community.
Exactly. It gives you the capacity for rational thought, for resilience, for emotional growth. It's key.
Okay, so that's health. What about the other side? Mental illness.
Mental illness, in contrast, refers to actual definable diagnoses. These are conditions with significant dysfunctions, could be developmental, biological, psychological, that really impact functioning.
So like changes in thinking, maybe like Alzheimer's.
Precisely. Or changes in emotion, like major depression, or even behavior like we see in schizophrenia. Specific, identifiable conditions.
That makes sense.
Yeah.
But, it feels like there's often a gap between that ideal WHO definition of complete well-being and how our healthcare system sometimes treats mental versus physical issues differently. And what about people who aren't, perfectly healthy but aren't acutely ill either? Is it just black and white?
Ah, that's a fantastic point, and it leads right into the mental health continuum. This is such a crucial concept because you're right, it's not black and white. Health and illness aren't like flipping a switch.
Okay.
Think of it as a spectrum, a line, and people. We're always moving back and forth along that line.
So at one end, you have good mental health, feeling well, managing life, no real impairment. That's where most people hopefully are most of the time.
Ideally, yes, that's the well-being end.
Yeah.
But then moving along, you might encounter, say, emotional problems.
What does that look like?
That could be mild to moderate distress, maybe some trouble sleeping, difficulty concentrating, feeling a bit anxious. It causes some impairment, but it's usually temporary or manageable.
And then the other end of the spectrum.
That's where we find mental illness, characterized by really marked distress, often chronic impairment that significantly impacts daily life.
The book gives this really powerful example, doesn't it? The 40-year-old woman describing her experiences.
It really does. She talks about severe depression as horror and hell, then mania as feeling incredibly alive, and finally recovery. And in recovery, she says she feels calmer, more peaceful and real.
What's so striking is she didn't just get stable. She built a fulfilling life with a serious diagnosis.
And that ability, that capacity for fulfillment, even with an illness, brings us right to our next point.
Right.
What influences where someone falls on that continuum? What pushes them one way or the other? We need to look at risk and protective factors.
Okay, risk and protective factors. These fall into a few big buckets, right? Like individual attributes.
Things you're born with or learn, genetics play a role here.
Then there are socioeconomic factors, like family, education, even food security.
Absolutely. And then the broader environment, political climate, cultural views, access to care, it all plays a part.
Out of all those, which factor really stands out as protective?
Hands down, it's resilience. We define resilience as basically the ability to get the resources you need for well-being. It's also about regulating your emotions effectively, not getting stuck in negative thinking.
So it's that bounce-back quality, adapting to tough stuff like trauma or loss.
Exactly that. It's incredibly important.
The book mentions a way to measure this, the brief resilient coping scale. Could you kind of describe that so someone listening can picture it?
Sure. It's an assessment tool. It gives you 4 statements. Things like, I look for creative ways to alter difficult situations, or I believe I can grow in positive ways by dealing with difficult situations. You rate yourself from 1 to 5 on each.
Okay.
Add up the scores, you get a total between 4 and 20. Higher scores, like 17 to 20, suggest someone is a highly resilient coper. It helps quantify it a bit.
That's interesting.
Uh,
And you mentioned culture as an environmental factor. How much does that shape how we even see mental illness?
Oh, hugely. Historically, what counts as mental illness is very much defined by culture. Think about the old diagnosis of hysteria.
Right. Mostly applied to women.
Exactly, tied to ideas about exaggerated emotions, weak willpower. But as women's rights changed and society shifted, that diagnosis essentially disappeared. It was culturally bound.
And it affects how illnesses present too, right? The source mentions things like running amok in Southeast Asia.
Yes, that sudden burst of indiscriminate violence. Compare that to something like anorexia nervosa, which, until fairly recently, was seen mostly in Western developed nations. Culture shapes both the definition and the expression.
So when we try to understand the causes of these illnesses, where has science taken us? We've definitely moved past blaming, mania germs.
Huh, yes, thankfully. For a long time, psychological theories were dominant. The idea that it was all about faulty thinking or upbringing.
But then came a big shift, right, with medication.
Precisely. The discovery of chlorpromazine-thorazine back in 1952 was a game changer. Suddenly, a drug could calm profound agitation by affecting brain chemistry.
Which strongly suggested the problem had a biological basis in the brain.
Exactly. That discovery really pushed the pendulum towards biology. But, science keeps evolving. Researchers realized pure biology wasn't the whole story either, which led us to the model that's most accepted today.
The diathesis-stress model. Okay, break that down, sirs. Why is this the prevailing view now?
It's essentially the ultimate nature meets nurture explanation. Think of it like this. Diathesis is the biological predisposition, the genetic vulnerability. It's like the gun is loaded.
Okay.
Stress is the environmental trigger. Could be trauma, major life changes, chronic stress. That's what pulls the trigger.
So it's a combination. You need both the genetic risk and the environmental stressor for most psychiatric disorders to emerge.
That's the idea. It helps explain why, for example, not everyone who experiences a terrible trauma develops PTSD, or why not everyone with a family history of schizophrenia actually develops the illness. You usually need both factors.
That model, that understanding, it must have really changed how we approach treatment, moving beyond just drugs or just therapy.
Absolutely. And that recognition really fueled a major social shift, the recovery movement.
Tell us about that. It wasn't just a scientific thing, right?
Yeah.
It came from people with lived experience.
Exactly. It gained huge momentum thanks to groups like NAMI, the National Alliance on Mental Illness, founded by consumers and families back in '79. They really pushed back against the old paternalistic model, where doctors just told patients what to do.
They advocated for patient involvement, for self-direction.
Yes. They champion the concept of recovery. And SAMHSA, the Substance Abuse and Mental Health Services Administration, defines recovery not just as getting stable, but as a process driven by the person to improve their health and wellness, live a self-directed life, and reach their full potential.
The book has that great vignette about Jeff, diagnosed with schizophrenia young.
Right. For 20 years, he felt like others were running his life. But then he got involved in a recovery support group, started leading his own care planning, guided by those 10 principles of recovery, like hope and peer support.
And his quote really sums it up. Nobody knows your body better than you do. They only provide you with the tools to get better. That's powerful.
It truly captures the essence of the movement. Now, alongside this social change, there was a massive scientific push happening too.
You mean like the decade of the brain in the 90s?
Exactly. Declared by President Bush Sr., it poured resources into research, leading to huge leaps in understanding neurotransmitters, genetics, and especially neuroimaging, seeing the brain at work.
And then the Human Genome Project followed, right? Which must have really cemented the biological and genetic links.
It absolutely did. And more recently, President Obama announced the Brain Initiative in 2013. The goal there is even more ambitious. Develop new technologies to map the brain in unprecedented detail, hoping to find ways to prevent, treat, and cure brain disorders, including psychiatric ones.
Wow. And maybe the biggest indicator of the scientific direction is how the National Institute of Mental Health, NIMH, is shifting its funding.
That's a really key point. NIMH started moving away from funding research based only on the symptom clusters in the DSM, the Diagnostic Manual.
Why the change?
Because they realized just grouping symptoms might not get at the root causes. So they launched the RDOC Initiative Research Domain Criteria. The goal is to find the underlying causes of mental disorders at the biological level, genetics, brain circuits, molecules, using things like imaging and genetic analysis.
So they're looking deeper than just the symptoms, trying to find the actual biological mechanisms. That feels like a fundamental shift for the future of diagnosis.
It really is. It's about understanding the why at a much deeper level.
Okay, so we have social shifts, scientific breakthroughs. What about the legal and policy side? Because historically, insurance coverage for mental health was pretty bad, wasn't it?
Oh, absolutely discriminatory. Plans could have much lower annual or lifetime limits for mental health care, higher copays. It created huge barriers compared to treatment for physical illnesses.
So there was a push for parity, meaning equivalence.
Exactly. That led to the Mental Health Parity Act in 1996, which was a start, but it was really strengthened by the Wellstone-Demarco Parity Act in 2008. That required large group health plans to provide equivalent coverage for mental health and substance use disorders as they do for medical surgical benefits in terms of things like copays and deductibles.
And then the Affordable Care Act, ACA, in 2010 took it further.
It did. The ACA made huge strides by banning insurance companies from denying coverage based on pre-existing conditions, which obviously includes mental illnesses. And crucially, it mandated that mental health and substance use disorder treatment must be included as one of the 10 essential health benefits in most plans. That really broadened access.
So better science, more patient empowerment, and improved access through legislation. That's a lot of progress. How does quality and safety fit in?
Fundamental. That's where QSEN comes in, the Quality and Safety Education for Nurses initiative. These are core competencies for all nurses.
Things like patient-centered care, teamwork, safety.
Precisely. And communication is key. The source uses the really tragic story of Betsy Lehman to drive this home. She was a health reporter who died from a massive chemotherapy overdose.
And the heartbreaking part was she knew something was wrong. She kept telling her providers.
But her concerns weren't fully heard or acted upon in time. It's a stark reminder of why patient-centered care, listening to and respecting the patient's experience and concerns, is paramount. It ties right back into the recovery principles, too. Patient voice matters. Safety depends on it.
Okay, let's shift gears slightly into our last section. How do we actually track mental illness in populations?
That's the realm of epidemiology. It's the quantitative study of how mental disorders are distributed in populations. Public health uses this data to identify high-risk groups and plan services.
And there are two key terms here we need to get straight. Incidence and prevalence. They sound similar.
But they measure different things. Incidence tells you about the risk of getting a condition. It's the number of new cases appearing in a healthy population over a specific time period. Think of it like the rate of new infections.
Okay, new cases? What's prevalence then?
Prevalence is the total number of cases, both new and existing within a population at a specific point in time or over a period. It tells you how widespread the condition is overall.
Got it. So maybe like the common cold might have a high incidence rate, lots of new cases, but maybe a lower prevalence at any given moment because people recover quickly.
Exactly. Whereas a chronic condition like, say, diabetes might have a lower incidence, fewer new cases each year, but a high prevalence because people live with it for a long time.
That makes sense. And another important term for nurses is comorbidity.
Yes, extremely important. Comorbidity just means having two or more disorders at the same time. It's very common in mental health.
Why is that so crucial for a nurse to know?
Because it complicates everything. For example, someone with schizophrenia often also struggles with substance abuse, or they might develop diabetes or heart disease, sometimes related to medication side effects. Knowing about comorbidities changes your entire assessment and care plan. You have to manage multiple conditions.
Okay. Now, when it comes to actually diagnosing these conditions, what tools are used? The big one is the DSM-5, right?
Yes. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition. It's published by the American Psychiatric Association and provides the specific criteria for diagnosing 157 different mental disorders. It's the standard framework in the U.S., and it's what this textbook is based on.
But you mentioned earlier there's a really important point about how we use it.
Absolutely crucial. The DSM-5 classifies disorders. It does not classify people. This is huge for reducing stigma.
So we say a person with schizophrenia, not a schizophrenic.
Exactly. Separate the person from the illness. The language matters. We should also mention the ICD-10-CM. That's the International Classification of Diseases. It's the global standard, used more broadly for all health conditions, including mental health. In the U.S., it's often used alongside the DSM, especially for things like coding, care planning, and insurance reimbursement.
Okay, so we have the science, the social context, the diagnostic tools. Where does the psychiatric mental health nurse fit into all this? What's their specific role?
Psychiatric mental health nursing is a specialized area focused on promoting mental health and well-being. PMH nurses assess, diagnose, and treat human responses to mental health problems and psychiatric disorders.
Human responses. What does that mean exactly? How is it different from what a psychiatrist does?
That's a key distinction, especially for the basic level nurse, the PMH-RN. The RN typically doesn't diagnose the disorder itself. That's usually the role of the psychiatrist or advanced practice provider. Instead, the RN focuses on the problems associated with the disorder.
So for someone with depression, the RN might focus on what? Insomnia?
Yeah.
Hopelessness? Risk of self-harm?
Exactly. Those are the human responses. And they use the nursing process assessment, diagnosis, planning, intervention, evaluation to address these problems. For nursing diagnoses, they often use standardized language, like from the International Classification for Nursing Practice, ICNP.
What kinds of interventions does the basic level PMH-HRN do?
Core functions include things like health teaching, about medications, coping skills, coordinating care with the rest of the team, providing supportive counseling, and importantly, milieu therapy.
Milieu therapy. Can you explain that term for someone new to it?
Sure. Milieu basically means environment. So milieu therapy is about structuring the environment, the physical space, the daily schedule, the social interactions between patients and staff, to be therapeutic in itself. Every aspect of the patient's experience on the unit is considered part of the treatment. It's about creating a safe, supportive, and healing atmosphere.
Got it. So that's the basic level RN. What about advanced practice, the PMH-APRN?
Right, this is someone with a master's or doctorate degree. Their scope is much broader. They can diagnose psychiatric disorders, they can prescribe medication, and they provide various forms of psychotherapy, individual, group, family therapy. They also often do consultation work.
So a significantly expanded role.
Yeah.
And the overall focus for all PMH nurses covers a wide range of issues.
Absolutely. The phenomena of concern, as the standards call it, includes everything from managing self-harm or violent behavior to dealing with co-occurring disorders to addressing problems with communication, functioning, memory. It's very broad.
Looking forward, what are some of the big challenges and opportunities facing the field?
Well, a major challenge is the increasing acuity, how severely ill patients are in inpatient settings. Often this is because insurance limitations mean people only get admitted when they're in extreme crisis. There's also a significant workforce shortage in many areas, and ensuring culturally competent care for an increasingly diverse and aging population is critical.
And the opportunities?
Technology is a big one. Telepsychiatry, using video conferencing and other tech for appointments, is really taking off. It's proving effective, especially for reaching people in rural areas or those who have difficulty leaving home. It can also help reduce stigma for people seeking care for the first time.
Okay, so let's try to synthesize this. We've covered a lot of ground if we boil it down.
Right. We established mental health is inextricably linked to physical and social well-being. The diathesis-stress model is the go-to explanation for cause biology plus environment. The recovery movement fundamentally shifted care to be patient-driven.
And psychiatric nursing.
PMH nurses use the nursing process, focusing on the patient's response to illness, often using ICNP for diagnoses. Diagnosis of the disorder itself relies mainly on the DSM-5. Basic RNs manage the milieu and provide core interventions, while APRNs have a broader scope, including prescribing and psychotherapy.
That's a great summary of these foundational concepts. But connecting it all back to the real world, the source raised one final, really thought-provoking point for anyone entering this field.
That's right. It points out something quite striking. Nurses are the largest group of mental health care providers by far. Yet, historically, they've often been missing from the table when major policy decisions are made.
Like the President's new Freedom Commission on Mental Health. It had psychiatrists, psychologists, but no nurses.
Exactly. Which raises a crucial question for you, the listener, as a current or future professional. Given your central role in patient care, what role might you play? Will you get involved in advocacy, maybe through NAMI or professional nursing organizations, to ensure that the essential hands-on perspective of nursing shapes the future of mental health care policy and funding?
That is definitely something important to think about as you move forward in this vital field. Thank you so much for joining us on this deep dive into the foundations of psychiatric mental health nursing. We really hope this helps you feel grounded and ready for what comes next.